It is my pleasure to welcome Dr. Herman, a physician at the Cardiovascular Center at Azores Hospital in Elst, Belgium. Today, we'll be discussing his late breaker TCT presentation, which is simultaneously published in JACC Interventions. It's going to be an AI-enabled ECG analysis if it improves diagnostic accuracy and reduces false STEMI activation, a multi-center US registry. Dr. Herman, thank you so much for taking the time to join us and share your expertise.
Thank you for having me.
First question is, I know you have a lot of, a lot of interest and a lot of background in this specific topic, and I kind of want you to, if you can just briefly walk us through the background of the topic and the question that you aim to answer in this study.
Yes, so we've looked at the performance of an AI algorithm in regional STEMI networks, and we've done so due to three reasons. So we see that with regional STEMI networks, there is a high false positive activation rate, mainly driven by activations by non-cardiologists. We also see that a lot of STEMI patients actually present with initial diagnostically challenging ECGs, STEMI equivalent ECG patterns. And then even more critical finding is that only 83% of STEMI patients presenting to non-PCI centers actually experience reperfusion delays, which is a very, very big proportion of patients. We've intended to solve this using an AI ECG algorithm.
I 100% agree, and we all know, especially the false activation and the importance of STEMI activations and the burden of that on healthcare. Can you walk us over, the methods and the results? On what did you guys find?
Yeah, so we've developed this deep neural network based on single 10-second 12-lead ECGs. It's called the Queen of Hearts, and it has been previously validated in a large all-comer study, but not in the US. So we've now looked at the performance of this algorithm in three US primary PCI networks. So we had University of California, Davis, UT Health in Houston, and Beth Israel Deaconess Medical Center. And we've really looked at the performance of this AI ECG algorithm versus standard of care decisions to activate the cardiac cath lab on the index ECG.
Perfect. And what did you guys find? How did the model perform? How was the rate of false positive activation different?
Yeah, so we've looked at over 1,000 STEMI activations across these three networks, and we found that only 58% actually had true STEMI confirmed angiographically. In other words, 42% were mimics, and these included biomarker negative patients as well as Minoka mimickers and type 2 MIs. Now, if we look at the performance of the AI algorithm versus standard of care, we see that the index ECG sensitivity of this deep neural network was 92%, while standard of care only identified STEMI on the initial ECG in 71% of patients. What's very interesting is that this increased sensitivity was not at the cost of a decrease in specificity. And we see that the AI ECG algorithm actually reduced false positive activations by fivefold from 41.8% based on standard of care to 7.9% based on standard of care. And the majority of these false positives that remained after AI model reclassification were actually Minoka mimickers. So these are patients that are very diagnostically challenging, and you cannot really rule them out based on the ECG interpretation only.
I know, and it's very nice. I went over the manuscript myself, and I completely agree. I think the beauty of this improved sensitivity and specificity is just important because we don't want to miss STEMI, but at the same time, we don't want to be awake all night with false activations. The application of the study was retrospective. How do we move forward? Is it time for a randomized trial?
So that's a great question. There is one randomized controlled trial that will be presented at TCT. It's a difficult 3 RCT. It's a very large RCT from Turkey. Over 6,000 ACS patients have been randomized based on clusters into an AI-assisted strategy versus standard of care ECG interpretation. And from the secondary endpoints that will be presented at TCT, we actually see the results favoring an AI-assisted ECG strategy, both in terms of door-to-balloon times, post-PCI, TIMI3 flow, as well as the presence of wall motion abnormalities.
Exciting. I think it's very exciting, and maybe it is time for hopefully routine application of these tools. Thank you so much, Dr. Herman, for your time, and I invite everyone to go over the full manuscript of this issue, but also to look forward for the trial result as well. Thank you, Dr. Herman.
Thank you very much for the interview.